Welcome guys to this video where we are going to look at the inherited causes of the hemolytic anemia. In the previous video we have discussed in detail regarding the hemolytic anemia per se, its clinical features, etiopathogenesis and how to differentiate between intravascular causes and extravascular causes. Now from this module onward we will go into look for the individual causes of the hemolytic anemia and look into the detailed mechanism, how they present to us and how to treat those causes. So first, in this first video we are looking into the inherited causes, and as discussed earlier, inherited causes mostly are due to intracorpuscular defect, or something is that is defect lies within the red blood cell itself. Now if the defect lies within the red blood cell, what are the level can the defect can be? Now the defect can be at the level of the hemoglobin itself, which we call to be hemoglobinopathy, or defect can be at the level of the membrane cytoskeleton, and also there is a metabolic machinery that links and keeps this hemoglobin and membrane cytoskeleton in order. There are lot of different enzymes which helps to maintain this order of this metabolism, and this enzymopathy can also lead to the hemolytic anemia. Alright. Now hemoglobinopathy, what do you mean by hemoglobinopathy here? So defect at the level of the globin chain can present as thalassemia and sickle cell anemia. Alright. Okay. So if you check these inherited causes, this list, these are the order actually. So defect can be at the level of the membrane cytoskeleton, which are usually mainly the now if you check there is defect in cytoskeleton, so this normal structure of the RBC will get hampered and result into different shape of the RBC, which result in spear shape or ellipsoid shape. These are the most common ones in membrane cytoskeletal defect, although there are other varieties present also. There can be hemoglobinopathy also, like sickle cell anemia and thalassemia, and enzymopathy. Most common one are G6PD followed by pyruvate kinase and glucose phosphate isomerase. Now sickle cell anemia has been discussed already prior to that, and thalassemia I will discuss in another video. In this video we are going to look at the defect of membrane cytoskeleton and enzymopathy. Alright. Okay. So this is the main RBC membrane, and this is nothing but a multiprotein complex. Okay, and this multiprotein complex and cytoskeleton are intimately connected to each other, and thus it helps to support the membrane stability, and at the same time it helps the RBC to maintain its shape and prevent it from deformation. Now if we check the function of this membrane cytoskeleton essentially has mainly three functions. Now first of all it forms the red cell envelope, and it helps to maintain the red cell shape, which is nothing but biconcave shape. And third, and one of the essential function, it helps to transport of electrolytes or metabolites such as glucose and amino acid from in and outside of the cell. So transport of nutrients. These are usually the three essential functions of this RBC membrane. Alright. Now if we check the membrane, this membrane are formed of multiple proteins. Mainly structural component are formed by this alpha spectrin and the beta spectrin molecule here, and there is ankyrin complex and junctional complex. Ankyrin complex consists of the ankyrin part, and junctional complex has main protein to be the band 3. Right. Now defect of any of this protein will lead to the denaturation of the shape, that is its biconcave shape will be lost and resulting into more of a spherical shape. Okay, the change in the shape due to this protein defect can be mainly three types, which has been seen. One is spherical form, which is also known as the spherocyte. It can be turned into ellipsoid form, which is known as ellipsocyte, or sometimes it can give a stomata-like appearance. Stomata-like appearance means the inner leaf of the biconcave shape gets denatured or destructured, resulting in a stomata-like appearance known as stomatocytosis. Remember, these abnormalities are almost invariably inherited mutations, right? And these diseases of this membrane cytoskeleton complex belong to the category of inherited hemolytic anemias. Now, as the red cell lies, they often exhibit more or less specific change, which resulting in this biconcave shape to be getting altered. Thus, the majority of the disease for time long before classifying as membrane cytoskeleton defect has been termed as hereditary spherocytosis or hereditary ellipsocytosis for very long time. All right. Okay. So, if we check these proteins can be divided, which gives the structure to the RBC membrane, can be divided into mainly of two types. So one group of protein is which is trespassing the membrane. It has two ends. One is hydrophilic end, which is directed towards the cytoplasm, and another which is directed towards the cell membrane, known as the hydrophobic end. And there is another type of protein present in this cytoskeleton, which is anchored protein. That is, there is a structure through which anchor is bound, and this protein gets bound to this anchor. This is the anchor here. Classical example of this anchor protein is nothing but glycosyl phosphatidyl inositol anchor protein, GPI anchor protein, which is also known as nowadays PIGA, phosphatidyl inositol glucose anchor protein. Okay, GPI anchor or PIGA anchor protein, or either there is hydrophobic and hydrophilic end with protein. So you can see here only GPA, glycosyl phosphatidylinositol, that is the anchor protein, and through which CD59 gets bound, and other proteins like band 3 or ankylin or band 4.2, all of these are hydrophobic and hydrophilic moiety attached to it. Okay, so this change, remember, if there is defect in any of them, for example, there is defect in alpha spectin or ankylin, all of this structure will be get destroyed, and this cytoskeleton structure which maintains the biconcave shape will be denatured and resulting into different shape, that is spherocytosis, ellipsocytosis or stomatocytosis. Now, as you can see here in this peripheral smear, okay, so here I am just pointing out this cell. You can find that the central pallor has been replaced by a disc-like opacity here, disc-like pallor, and this is nothing but stomatocytosis. And in this one you can find, let's look this one. Here the central pallor is completely lost, and this is completely ring-like opacity and almost a spherical form opacity, known as the hereditary spherocytosis. Okay, these are spherocytes. Now remember, these spherocytes are never the pathognomonic of hereditary spherocytosis. It can be seen in other conditions as well as like hemolytic anemias also. Okay, so coming to this inherited disease of the red cell membrane cytoskeleton complex. So what are the important things we need to look into here? So let's just dissect this Harrison table for better understanding. So first, let's talk about the hereditary spherocytosis. You can see majority of hereditary spherocytosis is due to ankylin protein defect. Then 25% is due to band 3, followed by 3% of is by band 4.2, and alpha spectin here is causing both hereditary spherocytosis and ellipsocytosis. So I can say from this table, I can say hereditary spherocytosis can be caused by ankylosing defect, alright, ankylosing defect, then band 3 defect, band 4.2 defect, and alpha spectrin defect. Now you can observe more clearly that ankylosing defect is dominant, autosomal dominant in nature. Then alpha spectrin is whereas recessive, and band 4.2 is recessive. So we can say band 4.2 and alpha spectrin are autosomal recessive, whereas ankylosing and band 3 are autosomal dominant. Okay, so hereditary spherocytosis can be due to mainly 4 protein defect, majority due to ankylosing followed by band 3. Ankylosing and band 3 both are autosomal dominant, and band 4.2 and alpha spectrin are autosomal recessive in inheritance. Now, similarly, if we check for hereditary eleptocytosis, so mostly it is due to alpha spectrin. It is around 65% is due to alpha spectrin, followed by 30% is due to beta spectrin, and also due to band 4.1 defect, 5% due to band 4.1. So in hereditary eleptocytosis, defect are due to alpha spectrin, beta spectrin, and band 4.1. Therefore, alpha spectrin is common to both spherocytosis and eleptocytosis. Now you can see all of those are autosomal dominant in inheritance. Alright. Now if we check to the other protein defect, if we discuss about important point of other protein defect, remember band 3 defect is associated with distal renal tubular acidosis, right? And this molecule, specifically piezo1 defect, is associated with dehydrated hereditary stomatocytosis, and this is autosomal dominant. Important point is that most of this hereditary defect are extravascular, and it helps, splenectomy helps in it, but it has been observed with piezo1 defect there is very high risk of thrombosis post splenectomy. So splenectomy is contraindicated in piezo1 defect. Alright, this piezo1, KCNN4, ABCB6 and SLC21 are mainly the channelopathy, and all of those are associated with, if you check the symptom, pseudohyperkalemia, similar to piezo1, potassium leakage, all of those protein defect are associated with pseudohyperkalemia. Right. Now this SL21 gene defect, which is nothing but GLUT1 glucose transporter. Where is the GLUT1 glucose transporter maximum located? GLUT1 glucose transporter is maximum located in brain. Therefore, SLC21 mutation, which leads to overhydrated hereditary stomatocytosis, is associated with neurological manifestation because this GLUT1 is present in brain as well. Okay. So what we have learned now? We have learned regarding this piezo1 moiety. It is associated with dehydrated hereditary stomatocytosis. ST is for stomatocytosis, right? Then we have learned about KCNN4. KCNN4 also causes dehydrated hereditary stomatocytosis. Both of these are associated with pseudohyperkalemia. Then we have SLC2A1 defect or GLUT1 defect. Here is the GLUT1. This GLUT1 or SLC2A1 gene defect is associated with pseudohyperkalemia plus neurological manifestation. And differentiating this GLUT1 from piezo1 KCNN4 is that this GLUT1 defect is associated with overhydrated hereditary stomatocytosis. Okay. So another important thing regarding ABCB6 is ABCB6 is ATP binding cassette subfamily B6 associated with familial pseudohyperkalemia. You can check in the table. It was written. So ABCB6 is associated with familial pseudohyperkalemia. And important point regarding this ABCB6 is that this was first observed in case of blood bags, means stored blood bags. So around incidence is 0.3% in general population. So out of 1000 blood transfusion, 3 blood bags were associated with pseudohyperkalemia, and it is one of the important reason why potassium level rises in stored blood. All right. Okay. So coming to the main discussion that we need to do is about the hereditary spherocytosis. So what we have learned now, this is usually autosomal dominant mostly, and autosomal dominant mainly due to Ankyrine defect followed by band 3, and there is also autosomal recessive form. Autosomal recessive form is due to band 4.2. all right, it is due to the band 4.2 and alpha spectrin. Now this autosomal dominant form will have important thing of family history present, whereas autosomal recessives are de novo in nature, there is no family history. Now what is usual presentation of hereditary spherocytosis? Usual presentation of hereditary spherocytosis are mild to moderate anemia around 9 to 11, in the range 9 to 12 range, and along with there is repeated extravascular hemolysis. Repeated extravascular hemolysis, why it occurs? Because as RBC membrane shape changes to form almost of a sphere, this modified RBCs cannot squeeze through the splenic sinusoids, right? It cannot squeeze through the splenic sinusoids and results into hemolysis. So to prevent it, spleen has to also modify its form, and modified its form into resulting into splenomegaly, and more of a spherical form of spleen occurs in it. Now there is extravascular hemolysis. Extravascular hemolysis, obviously bilirubin will rise. As bilirubin will rise, time to time we can give rise to gallstone formation. So clinical feature, if we talk about clinical feature is number 1, gallstone. Number 2, this gallstone can often time to time give rise to pancreatitis. And this gallstone and pancreatitis might have family history also, as these are autosomal dominant in nature. And once you suspect a hereditary spherocytosis, what you need to do? We need to go for special test. Special test involve the osmotic fragility test, acid glycerol test, EMI binding test or gel electrophoresis, and definitive test is molecular test. Alright. And but before that, some parameters in the blood report will give you the clue and hint that this can be hereditary spherocytosis. For example, MCV normal, but MCHC will be high. There is very rarely MCHC gets higher than more than 34, and this is one of the causes in which MCHC more than 34, and RDW, red cell distribution white, will be obviously more than 14%. Okay. So coming to this osmotic fragility test. Now osmotic fragility test is a very simple one. Now what is done here, it is in each blood is collected and kept at varying level of dilution of saline solution. Now as spherocyte shape is reduced in the form of sphere, and sphere is something which is the least of the surface area, and it is very much jam packed in it. So if you give extra volume, it will get easily lysed compared to the normal RBC. So if you check normal RBC, lysis starts around 0.4% of NaCl. This hereditary spherocytes RBC, which is spherical form, lysis start at very early at the stage of 0.7% of NaCl. And this early start of lysis and completion of lysis gives a specificity of this osmotic fragility test. So as you can see here, So point is not important at where lysis start, but you can see this lower one is at 1%. 1% complete lysis is done in both of the cases. Now 0.95%, there is also complete lysis in the up and the below sample. But start of lysis here is around 0.38. Right, 0.38, whereas here start of lysis is around 0.66. So after graphical representation, in the normal RBC, start of lysis will be this curve, this one 0.41, and there will be shift to right in case of hereditary spherocytosis. So shift to right is very much important in this osmotic fragility test. Okay, so what are the other tests employed? Other tests employed are acid glycerol lysis test, EMA binding test, gel electrophoresis, and molecular test, which is obviously the gold standard for diagnostic purpose. Now EMA binding test is one which is clinically used nowadays, and it checks nothing but it checks band 3 binding. Band 3 binding. What is employed here in EMA, or which is eosin 5-millimide dye binding test, it is nothing but a flow cytometric test. So in which a blood sample is collected with EDTA and used, and ESMA dye binds with the cell membrane protein. So this EMA will bind actually to cell membrane protein, mainly the band 3. Okay, so it will bind mainly with the band 3 protein. Now if there is deficiency of band 3, the peak of binding will be obviously low. So as you can see, this control is the normal healthy population, and this is the hereditary spherocytosis patient in which band 3 level will be low. Why band 3 level will be low? It doesn't matter what the mutation lies. Even if mutation is encarried, all of this complex will be getting hampered, and as all of the complex getting hampered, band 3 in the circulation will also be low in case of hereditary spherocytosis. So what we will get there will be low peak in case of hereditary spherocytosis. Now once we have detected and we know how they usually present, these are usually in asymptomatic in nature, and we have younger age of presentation. Jaundice is present, jaundice along with anemia. Sometimes there will be history of gallstone in the family, pigment gallstone, and recurrent pancreatitis history can be there. Family history will be autosomal dominant inheritance in the family member will be there, and there maybe as well as it is stage of chronic turnover and chronic anemia usually persist in this patient, there will be splenomegaly and abdominal heaviness can be other sort of presentation in such patient. Also, this is a stage of chronic hemolysis, and hemoglobin seldom goes below 8 or below 7. It always ponders around 9 to 11, and most of the patient is stable in nature, but there are some conditions. For example, there is ongoing infection, or there is crisis or increased requirement of hemoglobin, as in case of physiological condition in pregnancy, where this patient can go into decompensation, and once they go into decompensation, they can present in decompensation. So what are the presentation are number 1, gallstone plus young patient with hemoglobin of around 9 to 10 and positive family history. Number 2 presentation can be due to abdominal heaviness and ovulation which is found to be a splenomegaly. Number 3 presentation can be due to decompensation, that is, for example, decompensation can be for very reason, mainly be due to trigger. It can be trigger, can be infection, trigger can be pregnancy, trigger can be any sort of thing. So for example, a young pregnant patient who was apparently alright, hemoglobin was 11 to 12, but suddenly who came in hemoglobin of 6 and bilirubin to be raised. Okay, it can be also due to parvo B19 infection. Now from here we come how to treat this patient, or when do we need to go for treatment. Remember, As this is a state of chronic hemolysis and patient are usually stable, that doesn't require any kind of supplementary management apart from supplementing with folic acid for which is an erythropoiesis factor, right? Factor requirement for erythropoiesis. There are some cases when you need for go for splenectomy, and this splenectomy parts hold for almost all of the cases of the membrane cytoskeleton defects. These are the all membrane cytoskeleton defect, hereditary spherocytosis, eleptocytosis, and stomatocytosis, except for PIS1 defect, where we have already seen the splenectomy has been contraindicated due to the increased risk of thrombosis post-procedure. Now, remember one thing, as I have said regarding the diagnosis part, these are the tests we need. So, check in this diagnostic algorithm, nowhere it has been mentioned the peripheral smear part because spherocytosis is not pathognomonic for hereditary spherocytosis. Remember this thing. Spherocytosis can be seen in autoimmune hemolytic anemia. Therefore, all the patient, when you ever get a spherocyte in peripheral smear, should be tested for direct COMTOST, and autoimmune hemolytic anemia should be ruled out first before going for other tests for hereditary spherocytosis. Alright? Okay. So, what is the treatment? Treatment is supportive mainly, and as well as in some cases we need to go for splenectomy. Now, once we are going for splenectomy, when do we need to go? So, indication for splenectomy includes when there are severe cases, and severe cases splenectomy should be done within 4 to 6 years of age group. In moderate cases, we can delay splenectomy up to puberty, and mild cases there is no requirement of splenectomy at all. Now, one thing that you need to know is post splenectomy, what you need to go for? We need to go for vaccination for H. influenzae type B, mainly the capsulated organism, as risks of infection with capsulated organism increases. So, H. influenzae type B, Neisseria meningitidis, and strep pneumonia. Alright, okay. That's about the defect of the membrane cytoskeleton. We have learned about hereditary spherocytosis, eleptocytosis, and hereditary stomatocytosis. Now, coming to the next part, that is the enzymopathy. Now, enzymopathy are mainly for our understanding purpose is that it is very, very rare, and mostly they are asymptomatic in nature, right? Now, this asymptomatic in nature because this anemia part of this enzymopathy are all tolerated by 2,3-BPG. So, remember we have discussed about this chart also, that is the anaerobic glycolysis part. Here 2,3-BPG increases in response to anemia and helps in the supply of energy requirement for the red blood cell. Therefore, when there is such enzyme defects, 2,3-BPG rises and this anemia is oil tolerated. However, again, this oil tolerated anemia can get into state of decomposition as well as pregnancy in case of parvo-V19 infection, or whenever there is some sort of trigger or there is some medication ongoing which can interfere with the function of these enzymes. So coming to the most common one here, among those enzymopathy, remember, most common is only one is G6PD deficiency. But if the question is asked, which is the most common enzyme defect in glycolytic pathway, remember most common enzyme defect in glycolytic pathway is pyruvate kinase. But most common enzymopathy leading to hemolytic anemia is G6PD. And this is the following order of the defect. If you remember, G6PD, this is G6PD followed by pyruvate kinase followed by glucose phosphate isomerase. Okay. Now coming to the most common enzyme disorder of that one glycolytic pathway, which is pyruvate kinase. Remember, presentation can be of two ways. One can be that of the newborn itself as a form of neonatal jaundice, who are requiring phototherapy and exchange transfusion and ovulation retic count to be increased, suggestive of hemolytic anemia, and there is need of ongoing blood transfusion. Now, treatment is supportive as it is a stage of chronic high turnover. Folic acid supplementation has some role. Splenectomy is plus minus role. There is debatable topic. Some studies have shown to be promising result and some are ongoing studies going. Now, bone marrow transplant is also plus minus result, and recently another drug has been approved known as mitapivat. So if I speak about this pyruvate kinase deficiency, its clinical presentation is mainly, one is in case of as a neonatal jaundice and anemia, neonatal jaundice, anemia. Secondly, it can be due to decompensation at old age, and treatment is supportive. Splenectomy has plus minus role. Plus minus. Bone marrow transplant has plus minus role, and recent trial has approved one drug known as, not approved yet, it is in the phase 2, might be approved in later on. It is mitapivat. Okay, all right. Now let's move to the next disorder of this enzymopathy, and which is very much important to understand for us. So before moving to this disease, let's just look into this 2 map. Can you find similarity? Yes. In between 2 map, you can see Africa part is the most majorly involved, followed by the Asian part as well as the South American part. In both of the cases, this is similar presentation. Africa is the majorly involved, followed by the Asian part as well as the South American. So this is a graph nothing but representing the overall incidence of glucose 6-phosphate deficiency, and this is the transmission of malaria, mainly malaria of Plasmodium falciparum. Alright. So this epidemiological graphical representation itself represents G6PD deficiency. If it is so very much common, obviously will not be selected by nature with something very bad to it. It has some positive side to it, that is they are inherently means less susceptible to the Plasmodium falciparum infection. So while Plasmodium falciparum are more dominant, this is a selective acquiring natural changes into the RPC membrane which prevented it from Plasmodium falciparum infection. Right. Now remember, this is G6PD. G6PD is X-linked disease. So if something is X-linked, it is more common in males. Now, what are the usual presentation in G6PD? G6PD usual presentation is the male from coming from Africa or coming from the Middle East, mainly coming from Middle East or Africa, as it is X-linked. So there is similar history in the family present. Reaction after taking the fava beans or reaction after taking some of the trigger, mostly like drugs. Okay, so for our population and all practicality, drug is the most important part that we need to consider. And once you suspect that to be based on the history, like there is male members having similar history, family history of having reaction with drugs or taking after fava beans, or someone coming from the Middle East of African region, you need to go for G6PD. If it is low, there is no specific treatment required. We need to only counsel the patient regarding the known triggers. So what are the triggers that we need to know? For G6PD deficiency, we should know about the following triggers mainly. So most common for our perspective is antimalarials like primaquine, and clinically used like nitrofurantoin, antibacterial for UTI, and as well as another medication which is also used for UTI, that is phenazopyridine. and mainly in tumor lysis syndrome, that is Debapriyo case. So these are the 4 drugs that we need to know practically which is used. Also cotrimoxazole that is used. So primaquine, which is antimalarial, antibiotic like cotrimoxazole, nitrofurantoin, and as well as analgesic, that is fenzopyridine. Fenzopyridine is given as a local analgesic action for adrenal bladder. It is given at the dose of 200 milligram 3 times a day. Fenzopyridine, which is a potential trigger, and in case of TLS, which is used like Debapriyo case. These are definitive risks. The list is very much long for the possible as well as doubtful risks, but remember this definite risks with G6PD deficiency disease, which can lead to severe hemolysis. Okay, so from here we are moving to the next set of disease. Next set of disease, we have discussed about the G6PD, these enzymopathy disorders, we have pyruvate kinase defect, and we have discussed in detail about the membrane cytoskeletal defect, that is hereditary spherocytosis, eleptocytosis, and stomatocytosis. We are moving to the disease which are inherited hemolytic anemia, but due to intrinsic defect in the level of that cell itself. This is extrinsic to that cell, and what we call it to be atypical hemolytic uremic syndrome. Alright, now hemolytic uremic syndrome classically was described with E. coli like toxin producing Shiga like toxin, and which is O157H57. Right, now remember this atypical EQS is not related to E. coli. EQAS is rather related to E. coli, and it is due to the mutation in the following complement, mainly mutation at the level of CFH, CD46, MCP, CF1, C3, and CFB. These are nothing but complement protein, and MCP or membrane cofactor protein has got the best prognosis above all. Now what happens is this complement, what is the function of complement? Complement is there for opsonization and attack of any viral molecule. If it or bacterial or viral molecule which comes into the circulation, it phagocytes them. Complement identifies and helps to phagocytosis. So for example, suppose I have infection at any part of the body, whenever this part's complement will get activated. Now when this complement gets overactivated, when blood circulates through this part, whenever it kills the microbiome which activates the complement, it also starts killing these RBC membranes. These RBCs as well as some of the normal blood cell, phagocytes normal blood cell, resulting into anemia. Therefore this overactivation of complement, better to say improper activation of complement results into hemolysis. Now important thing to note it here is that this activated complement not only lyses the hemoglobin, it also starts to lyse the thrombocytes as well as, or the larger megakaryocytes, thrombocytes. So there will be decrease in hemoglobin as well as decrease in platelet count in such cases. And where is the lysis mainly, complement mainly activated in the small vessel? The part where the small vessel is very, very much common, there will be damage of endothelial cells. So mainly damage of endothelial cells and small vessel, like there will be defect at the level of the kidney, and has a very dangerous prognosis as well as in the other organs. Mainly, as you can see here, it can be defect at the level of kidney, at the level of CNS or GI tract. If it is at the defect at the level of kidney, it can present with proteinuria, hematuria, or hypertension. At the level of CNS, altered mental status or focal neurological deficit or seizure may be the presentation, and GI tract can be diarrhea and abdominal pain. Now, how can you suspect? You suspect that there is microangiopathic hemolytic anemia. There are Features of hemolytic anemia like decrease in hepatoglobulin, increase in LDH and cystocytes and peripheral smear. Thrombocytopenia will be there as platelet component will also be attacked by this complement, and decrease in the complement C3 level. Okay, so important thing is that this atypical HUS is more severe from than the Shiga-like toxin HUS, and even data says 15% of patient of this atypical HUS has mortality that is very high, and one who survived among this 50% landed up dialysis. This is so that's the importance of it. Now, how to actually approach this atypical HUS? You need to when to suspect actually HUS. One, there can be microangiopathic hemolytic anemia, that is decreased hemoglobin, serum hepatoglobin, elevated serum LDH and cystocyte on smear. Then check for the ADAM TS13 activity. If it is low, there is TTP. If it is more, that is ADAM TS13 activity is normal, check for whether coexisting disease is present or not, whether it is Shiga toxin associated, which is mainly in children. If it is no, consider it to be atypical hemolytic syndrome. And if there is coexisting disease is present, consider it to be secondary TMA. Sometimes this secondary TMA can be recurrent. That time you need to again evaluate for the atypical hemolytic uremic syndrome. Now, how to treat this? Now, as you can see, the main problem lies in the complement defect. So, best is to supply plasma pool with complement which are normal and not deficient in nature. Therefore, plasma exchange is the line of treatment. So, treatment involves the plasma exchange. Now, this was the dictum until and unless we got a better option, and which is anti-C5 complement inhibitor known as eculizumab, right? This anti-C5 complement inhibitor eculizumab is also used for PNH, okay, which we will look into detail. So this is about atypical HUS. In the next module, we are going to look into the acquired causes of the hemolytic anemia.